So hello everyone, and welcome to today's webinar on the future of HPV research, capitalizing on current opportunities. This webinar was designed with trainees and young investigators at front of mind, and so today we're joined by a panel of young investigators and their mentors to discuss the future of HPV research with a focus on laboratory science and public health. After a couple housekeeping items, we'll hear from Dr. Anja Sterbenc, mentored by Mario Poljak on the laboratory science side. And then Dr. Robine Donken, mentored by Dr. Gina Ogilvie, will present on the public health side. Following the presentations, we'll open the floor to discussion and Q&A with the four panelists. My name is Elisabeth McClymont, and I'll be the moderator for the webinar today. I am a postdoctoral fellow at the University of British Columbia in Canada, and I've been engaged in HPV research for the past 6 years. I'm also an associate board member of the IPVS. So just in terms of housekeeping, during the webinar, you can use the chat function to ask any technical questions or to network with other participants. Any questions that you have for the speakers should go into the Q&A function. And in that function, you may also vote up the questions that you most want to see answered. And then on the top right of your screen, you can click View to toggle between the different view options. The final thing we wanted to touch on to just set the stage for our speakers today is to remind everyone of the WHO's global call to action to eliminate cervical cancer. So elimination requires the maintenance of a cervical cancer incidence rate below 4 per 100,000 women years. And the three key pillars to the elimination strategy are vaccination, screening, and treatment. And in order to get on the path to elimination within the next century, each country is encouraged to meet the following goals on the slide by the year 2030. So they're having 90% of girls fully vaccinated against HPV by age 15, 70% of women screened using a high-performance test by age 35, and again by age 45, and having 90% of women with cervical disease receiving treatment and care. So some trainees or individuals not involved in HPV research may look at the current situation where HPV vaccines are available, screening and treatment have improved, and elimination of cervical cancer is being discussed and potentially on the horizon. And they might think that we've got things pretty much sorted, that there isn't a strong future for them in HPV research. But as we know, the elimination targets will be no small feat to achieve, and we're here today to discuss just what that future in HPV research might look like, and particularly in the context of the COVID-19 pandemic. So we're joined first by the first mentor-mentee pairing, which is Dr. Mario Poljak and Dr. Anja Sterbenc. Dr. Poliak is a professor of microbiology and immunology and head of laboratory for molecular microbiology at the Faculty of Medicine at the University of Ljubljana in Slovenia. He is also the past president of the European Society of Clinical Microbiology and Infectious Diseases. He's had a highly prolific career to date, authoring more than 400 peer-reviewed articles and giving more than 350 lectures at national and international meetings. He's been actively involved in HPV research for the past 30 years and has been a member of IPVS since 2002. Dr. Anja Sterbenc is a clinical microbiology trainee at the Institute of Microbiology and Immunology in Ljubljana, Slovenia. In 2017, she was appointed assistant for the field of microbiology and immunology at the Faculty of Medicine, where she regularly holds lectures and educational activities for students. She completed her PhD in 2018, which focused on the characterization of a novel HPV type, HPV 204, and she still remains actively involved in several national and international HPV projects. So Anya, please feel free to take it away.
Thank you for the introduction, and on behalf of Professor Poljak and I would like to thank the organizers for inviting us to give our perspective on this very important topic. So we come from this beautiful country, Slovenia, that is actually also the country of origin for 10 officially recognized and identified HPV types that were discovered by our research group in the past 10 years. And although there are still a bunch of HPV types waiting for us to be discovered, we believe that one of the main research focuses should be actually the second goal of the WHO's goal for cervical cancer elimination. And this is that 70% of women are screened for cervical cancer at the age of 35 and 45. Basically what we need to do is we need to scale up the testing. So in order to actually screen eligible women 2 times in their lives, we have to have approximately 1.5 billion HPV tests over a time span of 5 years. This recent analysis of the HPV tests available on the global market in 2020 actually identified 254 distinct commercial HPV tests and at least 425 test variants. And one would assume that having such an abundance of HPV tests is a good thing, but actually the problem is that approximately 60% of these tests are without a single peer-reviewed publication. And what is more concerning is that over 90% of these tests are not in line with the standards agreed by the HPV community. So basically, we are left with 13 HPV tests that are compliant with Myers guidelines for primary HPV screening, and 3 tests that were WHO pre-qualified. So in order to fulfill the WHO's goals for cervical cancer elimination, we need basically the whole range of clinically validated tests, from high throughput, fully automated platforms that are mostly suited for high income countries, to cheap and easy to perform or easy to operate point of care tests that would be especially useful in low and middle income country. In addition to that, we need a lot of laboratories, and we also need qualified laboratory personnel. Unfortunately, the global strategy to accelerate the elimination of cervical cancer had officially been declared or launched just about a month before disaster struck. So COVID-19 actually drastically changed not only all aspects of our lives, but it also drastically changed medicine, and preventative programs were one of the first to be put on hold. So this recent study aimed to specifically assess the impact of SARS-CoV-2 epidemic on cervical cancer screening, and it actually identified several worrisome issues. So out of 57 laboratories from 30 countries on 6 continents, approximately 3/4 of them experienced a supply shortage. Also, more than half of them reported temporary suspension of routine cervical cancer screening, shortage of personnel, and COVID-19 also negatively impacted research and development capacity and activity. Several laboratories also identified that the time to HPV test result was significantly prolonged, and approximately 1/3 reported delays in ordering equipment. However, one smart guy once said that in the midst of every crisis, there lies great opportunity. We should not focus on the negative aspects only, but we should also identify opportunities that were generated by the COVID-19 pandemic. And these, I think, are 5 most important standpoints that we should focus on. So because of COVID-19 testing, laboratories had to integrate fully automated sample to result molecular analyzers and platforms, which can then be used for large-scale HPV testing. In addition, the companies also promised that the multi-million euro investment in the manufacturing facilities will actually be a safeguard for the European supply, not only for SARS-CoV-2 assays, but also for HPV assays as well. There was also a great innovation around COVID-19 testing and also recycling of some of the neglected technologies. What is also important is that in order to support the organization and delivery of COVID-19 testing, there was a massive recruitment or let's say cross-training of staff, which will provide a large cohort of trained individuals for future testing, for example, for HPV testing. And also we experienced expanding the use of self-sampling. If molecular testing was up until recently only limited to reference laboratories, we're actually facing a rebirth of molecular diagnostics because of the COVID-19 pandemic. And this was probably most prominent in low-income countries, where basic requirements for diagnostics, such as electricity, facilities, and infrastructure, were most limited. And for example, at the beginning of the epidemic, Ethiopia was actually forced to send their samples for testing to South Africa because they didn't have sufficient facilities. However, with the course of the epidemic, they actually were able to reorganize completely, and they went from 0 to a total of 72 fully functioning laboratories with a daily capacity of approximately 14,000 tests. So we should not miss this opportunity to jump into the novel established laboratory facilities in the post-COVID or near post-COVID times. In addition, like I mentioned before, there were several innovative and rapid diagnostic approaches introduced during the pandemic. These tests and devices should also be used in the near future to allow a simpler and more cost-effective screening for HPV infection, especially in the world where screening for cervical cancer is not in direction of the elimination goal set by the WHO. We have here a whole variety of point-of-care tests, which can prove to be very useful in low and middle-income countries because of lack of trained manpower to run the more complex tests. So this fully automated sample in results out devices actually circumvent the need for any extensive training and provide the perfect solution to this problem, as they decrease the chance also of human error. Currently, we have the Gene Expert system as a way to enable a point-of-care testing for HPV testing. But the problem is currently the manufacturing issue, as it is impossible to secure several millions of these tests that would be needed for mass HPV screening. So research should be focused on how to design point-of-care tests for HPV screening. One of the recycled technologies is also loop-mediated isothermal amplification, or LAMP. The technology is far from new, but this fast, simple, and inexpensive amplification method that produces results within 30 minutes to, let's say, 1 hour under isothermal conditions is one of the most serious competitors to RT-PCR testing. It is actually suitable for rapid testing of large numbers of people, and because the products of LAMP can actually be visualized by naked eye, there is no need for expensive instrumentation in order to interpret the test. There is somewhat lower sensitivity of the test compared to RT-PCR, but the sensitivity is not the main test specific that we wish for primary HPV screening, so this probably won't pose any concerning issues. And also because of the very short time to result, this may actually be the method that will enable triage of HPV positive women on the same day of testing. And regarding the price, if we compare the price to the PCR, the cost, for example, of a LAMP for a detection of tuberculosis is now estimated at approximately €6 per person tested, so a very cheap option. Also, in 2019, there were 2.71 billion of people using smartphones, and this is another opportunity to combine the HPV testing with already existing appliances. So a common way of testing with a smartphone is to use them alongside with specially made labels which are designed to detect the presence of a specific substance, for example, in this case, HPV or COVID-19. So if the searched after substance is there, there is a reaction which generates some kind of a signal. It can be a light signal or a color or electric signal. And then the phone detects this signal and interprets it with a camera or a sensors or this kind of add-on devices. And what proved to be really useful during the pandemic is that most of these add-on devices or this additional things that can be put on the phone can be produced by 3D printing, which is a very cheap way to add this additional let's say products. So the results can then be displayed on the phone and or an app that is displayed and can be then also distributed to others or, for example, to relevant authorities. So as you may be aware, although isothermal amplification is very advantageous, it is sometimes also not possible to perform this type of test because of limited resources. Most often because of the need for electricity-dependent heating module. So the articles of this article actually develop a wearable microfluidic device that is combined with recombinase polymerase amplification, which enables simple and rapid amplification of HIV DNA actually by using the body temperature of a person who is wearing this device. So the body temperature at the wrist is actually enough to perform the RPA reactions. And with the cell phone based fluorescence detection system, this device can provide a result for HIV testing in about 24 minutes. An alternative to the time-consuming assays can also be found in the form of microfluidics. These are devices that are capable of manipulating minute amounts of fluids and extracting information from very small sample volumes. And it has been also increasingly used for point-of-care testing, or let's say bedside testing. And here we have an example of the fabrication process for a paper-based device using a printing and cutting process. And even though there still has to be a lot of research done on paper-based immunosensors, these biosensors are actually very cheap, easy to handle, and probably everyone now is witnessing these enormous amounts of plastic waste that are generated for COVID-19 diagnostics. So we will all be very delighted by the fact that the paper-based immunosensors are biocompatible and also biodegradable. So we will actually do something good for our environment as well. And here at the bottom, we have an example of a fabrication process of a microfluidic device based on compression molding. This is an approach that can actually fabricate a very large number of devices, which then, of course, influences the pricing of the test. As you know, CRISPR-Cas proteins are used for genome editing, but they can also be used for diagnostics. And in this article, the authors combined Cas double-stranded DNA's activation with isothermal amplification, and they actually created this method with a very complicated name, but it's short, it's easier to remember, detector, which enables rapid and specific detection of HPV in patient samples. And here on the right side, we can see a comparison with the classical PCR. Actually, the detector identified the presence or absence of HPV 16 and 18 very reliably and with a good correlation with the PCR-based signal, and the results was generated within an hour. So to take things even further, we can use also smartphone rather than specialized laboratory equipment to capture these small fluorescent signals that are generated by CRISPR-Cas. And this assay described in this paper actually achieved a sensitivity of 100 copies per microliter in under 30 minutes and was able to accurately detect a set of positive samples in under 5 minutes. So direct detection of For example, SARS coronavirus 2 RNA with CRISPR-Cas and a mobile phone offers a promising option for rapid point-of-care testing, and this could also be applied to HPV testing. However, despite their versatility and specificity, existing CRISPR technologies suffer from the requirements for upfront nucleic acid extraction, also large reagent volumes, and several manual steps, which are all the factors that prolong the process and impede use in low-resource settings. So in this article, the authors combined microfluidics, on-chip electric field control, and CRISPR to directly address limitations of CRISPR-Cas. And this method takes approximately 35 minutes from raw sample to result. Also, this plastic chip can be produced through the injection molding process that I briefly discussed earlier, and this chip then costs around $4 per chip, so a very low price. So last but not least, I would like to present a test named after a famous Indian fictional detective, which I believe is one of the tests that is about to become a game changer in microbiology testing. This test is actually based on CRISPR-Cas technology, so it provides excellent sensitivity and specificity. And it has two of the most wanted characteristics. It returns results very quickly in under an hour, and it costs approximately 500 rupees. So this would be approximately $6.75 per test, making it an excellent choice for large-scale testing, especially in low-income countries. Also, another thing that we should address is the wide use of self-sampling. I believe that the COVID-19 will actually make self-sampling and self-testing become the norm. And this recent analysis on the self-collection of swabs for HPV testing, there is a strong evidence from high-income countries that HPV self-sampling can actually increase cervical cancer screening uptake. But unfortunately, data from low and middle income countries are missing. So I definitely think that this is one of the research topics that needs to be addressed in the future. So to summarize, I believe that we are facing several challenges, but we should look on the bright side and use the technology and all of the advancements that were discovered during the SARS coronavirus 2 diagnostics. And also our aims should be in the direction of development of rapid, inexpensive, so if possible, less than €1 per test, and easy to interpret HPV test. And we also have to think about the approaches, how to include underscreened and hard to reach populations. Thank you.
Thank you so much, Anya. That was super interesting. Just wanted to remind everybody that if you have questions, to put them in the Q&A function, and we'll come back and address questions after both of the speakers have gone. So next up, we have Dr. Gina Ogilvie and Dr. Robine Donken. Gina is a professor in the School of Population and Public Health at the University of British Columbia in Canada. She's a Tier 1 Canada Research Chair in Global Control of HPV-related diseases and cancer. She's also a Senior Public Health Scientist at the BC Centre for Disease Control and Senior Research Advisor at the BC Women's Hospital and Health Centre. She's currently the PI on over $10 million in research grants, and her research is focused on both the public health and clinical aspects of reproductive health, sexually transmitted infections, HPV screening, and the HPV vaccine. Her findings have been highly influential in setting and directing health policy, both in Canada and globally. And her mentee today is Dr. Robine Donken, who is Program Manager for the European Consortium for Risk-Based Cervical Cancer Screening. She's also a researcher at the Amsterdam University Medical Center. She obtained her PhD based on studies performed at the National Institute for Public Health and the Environment in the Netherlands, and then completed a postdoctoral fellowship at the University of British Columbia in Canada, where she was focusing on the population-based impact of the HPV vaccine, as well as optimal immunization schedules. So welcome, Robine.
Thank you. Well, this was already shown in some previous slides, but just a quick reminder that we have primary, secondary, and tertiary prevention, for which primary prevention aims to avoid contracting the disease, secondary prevention at early finding the disease, and tertiary of increasing quality of life and reducing symptoms in those who have already encountered a disease. And today I will focus on primary and secondary prevention. So currently there are 4 licensed HPV vaccines available, as you all might know. And Cervarix and Gardasil are the vaccines that are the longest around. And these prevent both against HPV 16 and 18, and Gardasil also includes 6 and 11, which is responsible for about 90% of all anogenital warts. Then the Gardasil 9 vaccine was developed, which includes 5 additional HPV types. And then recently, Secalin was marketed by the Chinese Innovax company in collaboration with GSK. And this protects against HPV 16 and 18. The first 3 vaccines are all licensed in both males and females, and the last vaccine is currently only licensed in females. So where are we with HPV vaccination? Currently, over 109 countries have implemented HPV vaccination in their immunization programs, and another 24 countries are currently planning introduction. And I think that is a great achievement. Unfortunately, at this point, most countries, so about 4/5 of those countries, have a female-only program. But the number of programs that are gender neutral is increasing. And there is a highly variation with regard to vaccine uptake, not only within countries, but also if you look globally. And also if you look at countries that have been able to implement HPV vaccination, as you can see in this map, HPV vaccination is not really equitably distributed among the globe. But there are also large successes. So in countries where the HPV vaccine has been introduced, we've clearly seen impact with regard to HPV infections, anogenital warts, and precancerous lesions, as was shown in the review by Melanie Drelay. Also, we've seen several data linkages so far from Scotland, from Canada, from Australia, where clearly direct vaccine effectiveness in those who have received the vaccine versus those who are unvaccinated has been shown. And in addition to that data, we also see the first indications in Finland, based on this publication from 2018, that the vaccine also has a clear effectiveness on a population level against HPV-associated cancers. So I think we can all agree the HPV vaccine works, and it does very well. But besides this great efficacy and effectiveness, the success of vaccination is also driven by vaccine uptake and coverage. And an important driver for that is the vaccine confidence. And negative media attention can really threaten vaccine confidence in a population, as was shown in Denmark, where after negative media attention, vaccine uptake declined very rapidly. And what we've known after that is that a very broad, multidisciplinary, rapid response to these kind of negative messaging can help restore the confidence in vaccination programs. So really getting together cancer organizations, OBGYNs, family practitioners, to have one clear message that the HPV vaccine is safe and very effective. And as Anya already indicated, in every crisis lies great opportunity, and with the current ongoing pandemic, I think this is the time to show the world the great scientific achievement that vaccination is. but it also gives us room for new questions. So as recently with correspondence around possible side effects related to COVID-19 vaccines, it brings us the question, how can confidence in vaccine or communication about vaccines maybe influence vaccine confidence for other vaccines as the HPV vaccine? And I think we can see clearly two directions with regard to that. So first of all, having a pause in programs might provide people with confidence and more insight about all the precautions we are taking with regard to the safety around vaccines. So it might strengthen the thought of people that there is a thorough research with respect to this with respect to the problems. But on the other hand, it can also cause fear, and people might become more reluctant to not only take the COVID-19 vaccine, but also other vaccines. And it's really hard to predict which direction it will exactly go, but it is at least an opportunity to inform people about what is behind vaccine research. And also, with more and more data becoming available about the great impact of COVID-19 vaccines and their effectiveness, might cause people to have more confidence in other vaccines as the HPV vaccine. Another research opportunity in the next 5 to 10 years, I think, is also driven by a current limitation, since there is a substantial shortage of the HPV vaccine at this point. So this is a figure from 2019 where you can clearly see that the demand in green is higher than the supply, which is indicated in yellow. And so far, the Gavi Vaccine Alliance already has needed to delay the introduction of several HPV vaccine programs in developing countries. On the other hand, also this provides a great opportunity to do some more research. And one of the important questions is whether we can limit the number of doses that are needed for a successful vaccination course. Data so far is really coming from observational studies, as the Costa Rica vaccine trial that was originally designed to study the effect of 3 doses compared to unvaccinated. But some women suspended their vaccination course after 1 or 2 doses. And what can be seen is that 1 dose has substantially lower antibody titers than 2 and 3 doses, although higher titers than what compared to naturally infected participants. And the true meaning of this remains a little bit hard to define, since we don't know what the correlate of protection for HPV vaccines with regard to the immunogenicity is. But on the other hand, and we can see that in the figure with these bars, and this is data from both the Costa Rica vaccine trial and the Patricia trial, we can see that the persistent infections with vaccine types HPV 16 and 18, incident infections, are really comparable after 3, 2, or 1 dose. So this is going to lead to a whole cascade of studies in the next few years that are going to look into whether a single dose might be enough. So all 3 vaccines from GSK and MSD are represented in these studies at this point. There are several RCTs, but there are also some observational studies. Some studies will only look at immunogenicity endpoints, others will look at effectiveness endpoints, and some of them will combine these 2 endpoints, which will also allow bridging between the studies. So I think the single dose, we can expect a lot with regard to data from that question in the next few years. And also we need to consider what this might mean for immunocompromised recipients of the HPV vaccine. And it's really important to also include them in these or comparable trials to get a better understanding if 1 dose would also be enough for them. Another question could be whether we could extend the second dose, especially in adolescents, till beyond the biggest crisis with regard to the constrained supply, so for about 5 years. And what we need to consider is then that we are making sure that we would still vaccinate the majority of adolescents before their sexual debut, since we know the vaccine is most effective before the onset of sexual debut. But if we can come up with a schedule, like for example, first dose given at 9, second dose given at 14, we might be able to delay that second dose in such a majority of people that it might be possible to catch up the demand and supply at some point, and things get more easier. So this is a recent paper submitted by Collins Fairclough, where we looked at what extending the interval from 6 months to 12 months, and that is the figure on the left, would mean with regard to the GMT's 1 month post-vaccination. And we saw that 12 months actually provided comparable or even better antibody responses than administering the second dose at 6 months apart. And then on the right, we also looked, and this is based on a study where the second dose was extended 3 to about 8 years post first dose. And then if you look 1 month post the last dose, you can see that for HPV 16, 18, and HPV 6, there was non-inferiority using the 0.5 margin with regard to antibody titers. However, for HPV 11, we found that the response was, we could not conclude inferiority. So I think what we can say for now is that it might be worthwhile to have a better powered study as well, looking into extending that second dose beyond the 12 months mark. Another way of saving HPV vaccine could also be to look at alternative delivery. So currently the vaccine is administered intramuscularly, and we know from hepatitis B, but also influenza, that when you deliver the vaccine intradermally, this might require less of the doses. So currently there's a large US study where they look at immunogenicity after administering 1/5 of a single dose intradermally, and whether this is non-inferior to delivering it intramuscularly. And then also on the good news part, there are several newly developed vaccines on the horizon as well. So one of the examples is the producer of the Secalin vaccine, Innovax, which I mentioned earlier, is currently also trialing in phase 2 a 9-valent vaccine. So we might get more HPV vaccine production over the next years, and who knows what scaling up all those vaccine manufacturing facilities at the moment might mean in the long term for other vaccines as well. Well, other related questions to vaccination are maybe that what is going to be the impact on diseases that are currently not registered for the HPV vaccine to prevent, but we might be able to clearly observe some impact there. So the rate of HPV positive oropharyngeal cancers has been rising in several countries in the past years. And one of the hard things with oropharyngeal cancers is that we do not have clearly defined precursor lesions as we have at the cervix and the anal side. But in a few years, with vaccinated cohorts maturing, the impact on oropharyngeal cancers will become apparent. And I think that is an interesting observation, which I'm really looking forward to. And then secondly, we might also see a decline in juvenile onset recurrent respiratory papillomatosis, and this is data from Australia. And RRP is very rare, but there was a clear decline observed 5 to 10 years post-vaccination there already. So I think getting more data from other countries, and especially comparing countries that are using vaccines that are not targeting 6 and 11 versus countries that are targeting HPV 6 and 11 in their vaccines is really interesting. And then another research question might be whether mixed schedules might also solve some of the problems with regard to the shortage. Till now, there was always the paradigm of using the same product for the full course of the immunization. And based on this study from Quebec, it was shown that after a mixed schedule of administering bivalent and nonavalent vaccine, the titers for HPV 16 and 18 were higher compared to 2 doses of the nonavalent vaccine. And currently, Quebec is using this schedule in their immunization program. So I expect some more data about that in the next few years. And then another interesting question is whether the current prophylactic vaccines might have a therapeutic effect in people that already have developed anogenital warts or CIN2+ or AIN. And this is an Iranian study which showed about 60% efficacy of the prophylactic HPV vaccine against CIN with regard to recurrence or resistance of the lesion. So I think that the prophylactic vaccines are one, and then there are also several therapeutic agents under development that might have a treating effect. Then with regard to screening, so the secondary prevention, as Anya already indicated, the current pandemic has caused problems with the screening programs in forms of suspension or limited supplies. And I think still there are still a lot of people that might be hesitant to go to their healthcare providers or who encounter difficulties visiting them. And an alternative for sample collection, as was already indicated, might be self-sampling through either urine or cervical self swabs. And this becomes especially available in countries that have switched their screening programs from pap smear testing to primary HPV-based testing. So primary HPV testing, we know that has higher sensitivity but a lower specificity for the detection of CIN2+, and therefore we need triage of HPV positive women. This can be done through cytology, but then we would still require a pap smear for that women to be able to do the cytologic evaluation. So other options that could be performed on the self swab could be partial genotyping or the evaluation of viral or host cell methylation, and also P16 staining could be an option for a better triage of HPV positive women. Then another challenge in the next few years is that in several countries, although there is a very effective screening program, we see an increase in cervical cancer rates, and this is due to a higher HPV prevalence. So we really need a more efficient screening to keep it affordable in these countries. Besides, also in the next few years with regard to screening, the impact of vaccination will become very clear. So there are the direct effects with regard to vaccination. So we know that HPV vaccinated women have a way lower risk of developing CIN2+ than HPV unvaccinated women. And then secondly, there are also, of course, the indirect effects. So women who are unvaccinated but live in a country where almost everyone around them is vaccinated might also have a lower risk than unvaccinated women in countries where the vaccine coverage is lower. And then, given our clear understanding of the natural history of HPV, we know that some women are at a higher risk for the development of cervical cancer in the long term. So we know that some genotypes might cause a higher risk. We know that women who are not previously screened are at higher risk. And we also know, for example, that women who are smokers are at higher risk. So if we would take these risks into account, we can develop risk-based screening algorithms. And an example of this is here on the left, where the US guidelines are illustrated. So they have illustrated the current and the 5-year risk for CAN3+, and they've done that for women in which the previous screening results are available or are currently not available. And they also distinguish based on HPV positivity in the previous round. So by taking into account these differential risks, you can really inform your clinical management. And as indicated, I'm the program manager of the risk-based screening, cervical cancer screening consortium in Europe. And the ultimate aim is to develop a risk-based screening program through different stages. So first we will develop several risk profiles, either based on screening history, on vaccination coverage, or on individual risk factors. And this will inform a cost-effective modeling program that will lead to an algorithm that we can use to develop an e-health platform that can be used to pilot in European countries. So women will be invited based on their individual risk factors, or they can stay away for follow-up a little bit longer. And then ultimately, we will also develop e-learning tools for physicians and researchers around this topic. And then other screening related questions in the next few years, I think an ongoing discussion will be about latency. So when we have detectable HPV at a screening round, there might be several reasons behind why we are detecting that HPV at that time point. Could be a new infection, it can be a recurrent redetection. And I think that is really important with regard to the primary healthcare providers who need to counsel a woman who might have been positive in the past, then became negative, didn't have a new partner, and then becomes positive again. And I think it's also going to be interested if these women are at different risks when we are measuring them in HPV-based screening. And then finally, I think the microbiome will remain a field where we remain interested. We know that people with a low pH in their vaginal environment have a lower HPV positivity. And we also know that a less diverse microbiome environment can lead to more progression. And this raises the question if altering the microbiome by either pre or probiotics might have an effect on cervical cancer in the long run.
Okay, thank you so much. We now have a little bit of time left, 10 minutes for Q&A and discussion. There have been some questions coming in. So first of all, for Anya, what do you believe to be the advantages or disadvantages of including methylation assays as a triage strategy for following up women who test HPV positive? And Robine, you might also have some thoughts on that as well.
Yes, thank you for this great question, but I believe my mentor, Professor Poljak, has much more experience than me, and I think he will be glad to answer this question.
Okay, so methylation assays, the greatest advantage of any triage assay, including methylation, it's if we can perform triage from the same sample which we use for the screening. So this is the most critical issue. And if we are going, or we will be forced to go to the self-sampling, cytology, it's not cannot be considered as triage in self-obtained samples. So then methylation or genotyping, limited, extending, full, whatever, then become the first choice. So what we need for the methylation, actually, what is disadvantage still, it's a quite complex procedure. We need also point of care test for the methylation. We need to reduce the cost significantly. And I think this is actually a room for, I think there is a scientific evidence that methylation, it's one of the most top methods for triage of HPV positive wound, but we need to work on the more simplest, cheapest, and affordable assays. I think this is the area for research, for the young researchers to focus on.
Okay, thank you. We have a couple of people wondering if urine can also be used for HPV genotyping.
I can also maybe jump here because we also have experience here. For the urine, we can use urine for diagnostic purposes or for surveillance purposes. For the surveillance purposes, there are several countries which actually choose urine as the best way for surveillance, for example, after the HPV vaccination, and it's working very well. For diagnostic purposes, originally the problem was collection device. I think we made a substantial improvement here to develop device which is affordable for the all 3 or 4 genders, not only 2, and we can stabilize the urine to be stable. We find a way how to concentrate the urine to have enough DNA for detection, and also genotyping is absolutely positive. So there is nothing. Only what is just different from the cervical swab and urine. It's actually covering the larger area of the genital urinary tract. So maybe we can detect some of the genotypes which are not present in cervix, but in other areas. And this can maybe lower the specificity of the whole approach. But, giving all advantages of the urine, I think urine is one of the top self-sampled sample types for the future to be looked for.
Okay, thank you. So, we had some questions before and also now about the impacts of the COVID-19 pandemic on HPV vaccination. And Robine, you touched on that a little bit, but I'm wondering if you can speak a bit more about how HPV vaccination programs might have been affected, if you're aware, and what the most promising strategies are to improve HPV vaccination in low-income countries despite these impacts.
Yeah. I was actually trying to find some data, like more recent data, if introduction maybe for like in many countries, HPV vaccine might be the most recent addition to their screening program, and to what extent this might have influenced other programs. And of course, COVID-19 vaccines are now currently introduced on a total different scale. But unfortunately, I don't think anyone is really tracking the real impact with regard to numbers, but at least the program managers for national immunization programs I was speaking to in the past days indicated to me that when the HPV vaccine was introduced, they didn't observe a decline in other vaccines. So I think people might make that decision differently. But I think there is an important job for the whole scientific community to clearly communicate that although very rare, sometimes side effects happen and what that might mean, and how safety assurances are in place, and to clearly explain what is going to happen now, because I think we've all heard from family members like what is going on, or at least within the Netherlands, we're pausing this vaccine and then we're continuing in. And I think it is really important that we communicate in a very layman friendly way what is going on, and not only we, but the scientific community from a broader perspective. And I think it is also a time to clearly underline what a great achievement it is that these vaccines can be developed in such a short time frame, but that is due to work that has been done for many vaccines in the past decades.
Right, okay, thank you. I have one more question for Anya. You showed us some amazing new technologies. For somebody who's not involved in lab science, it's really incredible. But what is it going to take for some of these to become widely available? What additional research needs to happen to get us there?
Like for on that slide that I showed, that there's a bunch of tests already available on the market. We need, of course, additional testing to be performed, and these new tests need to be validated by the scientific community in order to achieve or at least be good enough for primary HPV screening. This will of course take some time, so it's not very rational to expect that this will happen next year or in the near future, but this is definitely the way that we should pursue. There's going to be a lot, I think there's going to be a lot of research, and there are already a lot of how to say, very good collections of samples that this test can be studied on. So I believe that this is the future.
Great. We are running out of time, and so as a last question, I just wanted to bring things full circle for our young investigators watching, and to ask the mentors that we have present today, given the current state of HPV prevention, screening, and treatment strategies, and the focus on cervical cancer elimination in the next century, do you think it's a good time to engage in HPV research? And do you have any additional advice for those just starting out in the field?
Sure, I can jump in here, and congrats to both of you for just really incredible presentations and great summaries of where we're at and where we need to be going. I think it's a super exciting time to be in this field. You know, when I started out, and a couple of my colleagues who were working on this, you know, we would say HPV, we would say cervical cancer, and people didn't even know that we were focused on it, and they didn't know there were innovations and opportunities. I think now that the WHO has named it as a priority for elimination, there is a shared understanding that there's a real need for some of to answer some of the great questions that were posed today to achieve that goal. And it's a huge goal, right? Let's be clear. We have 500,000 women a year, you know, who are developing this cancer. So we've got a lot of work. From the public health side, I'll say that I think Robine really highlighted some of the real opportunities. And you know, I'm a very sort of pragmatic thinker, and so when we think about primary and secondary prevention, coverage is really critical. And you know, Mario talked about how some of the challenges with sort of triage is if you have to take a second specimen, that is not going to be functional. That is not useful. So it's those sort of practical, pragmatic questions and aligning it with creative, innovative thinking that's going to be the next field. And I think some of the stuff you saw today also shows how what we're learning is applicable broadly. So thinking about, I love the presentation talking about CRISPR and how that relates to diagnostics. Massive opportunities there. Robine linked together vaccine confidence as it relates to HPV vaccine. And we know that then is going to link to COVID-19 vaccines. So I think really thinking about coverage and how do we get the tools, how do we develop innovations that allow improved coverage for these innovations that we know work. That's how we're going to get to our goal of elimination.
Okay, so I can also add, and I completely support what Gina said. I think this is now the best time to start HPV research ever. I mean, to be honest. So when I started, I mean, it was 30 years ago, it was not really a popular field, you know, I mean, and if you are working as a young scientist in the field where only hundreds of people are working, I mean, potential outcome of your research could be, you know, few good papers, but, you know, general outcome will be limited because it's a limited number of the people who will receive your message. But now, you know, having disease which WHO not very frequently actually appoint some disease as a target for elimination, because for this you need to have huge arguments. And you know that we are very close to the polio eradication, or almost not only elimination. There is only 2 infection diseases in addition, which WHO is now putting all efforts for elimination. One is hepatitis C, when we have fantastic diagnostics and fantastic drugs, but still we have no idea about 90% of the hepatitis C affected people living in the world. We have no idea who these people are because we have no affordable diagnostics. And the same story is also for HPV. So this is the second one, which we have clear elimination goal. We have fantastic, you know, we never had such powerful tools like primary and secondary screening, and HPV vaccination. And I really think that this is now the best. We have so many questions to address, you know, so many people to screen, so many people to vaccinate, or both genders. We are far away, and we need the manpower. We need the power of the young people who will stay together with the good ideas. You know, look on the CRISPR. You know, I mean, 2012. It's only first time published, and 2020, 8 years later, Nobel Prize. I mean, it's a fantastic and such broad use of the method. You know, from modifying genomes of the eukaryotes, prokaryotes, you know, to the diagnostic field. So it's something really. It's a completely new young field, and whatever you did will have really huge impact. So it's really the best time ever to start HPV research. This is my recommendation after 30 years working in HPV. Thank you.